Okay, so this would be a supplement of the two videos that I have asked you um, to view prior to this lecture. So we will apply all that we have learned so far with regards to normal pregnancy, evaluation of the pelvis, and the like. And we apply it to a patient um, so that you would appreciate more the things that you are learning, and you will learn how to apply it in more or less a patient. Okay. So what are the things that you have learned offhand with diagnosis of pregnancy in the lecture? What are the things that struck your imagination or struck your mind? What stuck to your head?
Absence of period.
What?
Absence of period.
Okay. So absence of period. So we start. So a patient comes to your clinic, doctor, I have had missed menses. So what kind of sign of pregnancy is that?
Presumptive sign.
Presumptive sign.
Okay, so you have your presumptive, you have your probable, and you have your positive signs of pregnancy. So presumptive meaning what? It is still not certain that a patient is pregnant. So in this case, amenorrhea is a presumptive sign of pregnancy. Why? Why would amenorrhea just be a presumptive sign of pregnancy? What
Because
would
there
be
may
the
be
other
some other
causes of
diseases
amenorrhea?
that may just imbalance the hormones, and that may cause the amenorrhea. So that's not the sure sign of pregnancy.
Okay, there are other causes of amenorrhea in a woman, in any patient. Okay, so this patient comes in um, complaining of missed menses. Okay, as the medical clerk, medical intern, or resident, what are the important things that you have asked? You have had your history taking, right? In obstetrics with Dr. Ina, history and physical examination. We will correlate it now with your diagnosis of pregnancy. I'm sure some of the items that I have touched on during my two lectures have already been touched by Dr. Ina. I am just re-emphasizing it so that we could apply it. Then more so when you have your lecture next week on prenatal care. Okay, so Miss Menses, what are the important things that you have to ask the patient to rule in, rule out your differentials? So that we could have a diagnosis of pregnancy in this case.
We look for the secondary amenorrhea.
You ask if there's secondary amenorrhea. So how will you elicit secondary amenorrhea by asking the patient?
Absence of period more than 3 to 6 months.
How will you ask that to your patient?
Doctor, by asking if the patient had any sexual intercourse.
So you ask, when was your last sexual intercourse? When was your last
Yes, doctor.
menstrual period? And your last previous menstrual period. So those are two important dates. Why is that important? Why is that important?
First thing, ma'am, we will able to know about the chronic or long time or a acute kind of the disease and maybe infection there. And second one, for the calculation, if she is really pregnant, then it would be also helpful for the calculating of estimated delivery time.
Okay. With your first day of your last menstrual period, what would be the information that you could get? You could get your estimated date of confinement or your EDD. How do you compute for that?
First of all, we will just minus 3 months from the date of menses, first date of menses, and then we will add 7 days in that, and then we will add 1 year in that.
Okay. So that is your estimated date of confinement, which is equivalent to your 40 weeks. Okay.
Yes, that.
What else could you get from your from your last menstrual age? You could compute for age of gestation. Okay, what is your age? How do you compute for your age of gestation? Without using your smartphone. I know it's easy for you guys to just have your smartphone ready. There are apps that will just ask you for the date of your last menses and you will get your age of gestation. But how do you compute that without tape, without your smartphone? Anyone?
The quickening, then using the tape, measuring tape.
No, not physical examination. All that we have so far is your first day of your last menses. So how will you compute for your age of gestation?
Ma'am, we have to go by month. Like for example, recently in our one of question of quiz, we got the 5th of January. So if today is 29th of April, then we have to go day by day, like in month of 31st January means 31st day in January. So we have to just minus and then add the month by month, and we have to go through this pattern.
Okay, so in our case, I gave a last mens of January 5, 2021. And what would be our EDD? What did you get?
October 12.
October 12, 2020.
October 12. So for some who missed the format, I will check. Don't worry, to see if what went wrong with the formatting. Okay.
Ma'am, one more thing, ma'am. In that same question, in that given answer that you have given, that was written like October 2021, but that's wrong. That should be October 2022.
Yes, ma'am. October 22 should be.
No, it should be
Okay,
October
I will check.
2021 only. Because
Ma'am, it will be 21 only, ma'am. If it is 22, it will be one more year she should wait for delivery. It's almost the nonsense. So she will deliver in this year in October only, ma'am. That's 9 months.
Don't change of the year. I will check. I will check your answers. Don't worry. Okay. So how do you compute for age of gestation then? So as mentioned by your classmate, 31 minus 5 is 26 plus 28 plus 31 plus 29. And that will give you a total of, then divide by 7, that would roughly give you how many weeks? Age of
16 weeks
gestation.
and 2 days.
So it will give you roughly 16 weeks and 2 days. Okay. Trick questions when it is given in exam, as you have mentioned, you are given dates that would change month or change year. So for example, if it's January 25, when you add 7 days, it would be turning the month. So make sure that you deduct the corresponding month accordingly. Otherwise, you will be off for 1 month. So those are, or you will have a change in year. You will have a confusion as far as the year is concerned. Okay. So this is a basic OB1 skill. Computing for your last menstrual period, EDD, age of gestation. So know this at the back of your hand. So more often, this would just comprise a two-step question. What do I mean by two-step? You are asked to get a certain fact, but you have to compute for your last menses first before you could answer the question itself. Okay? So age of gestation and normal and last mens EDD clear. Okay. So what else will you ask the patient? Patient has missed menses. You know that she has had a positive pregnancy test by HCG. So you have computed the due date. You have computed for the, what are the important things that you have to elicit?
We'll check for the beta HCG.
Okay, what is the role of your beta HCG?
It increases after having the pregnancy.
Okay, your beta HCG increases. What else?
Maintains the corpus luteum.
That is through sonography. But you have your corpus luteum, okay? And you look at it to avoid potential problems. Is the baby in utero? Is it an ectopic pregnancy? Would there be a tendency to have an abortion? So those are the things that you have to know. So you have your history. It has been extensively discussed by Dr. Irabon. Okay. Okay, so history, first trimester, second trimester, and third trimester, you have seen in the video that there are different problems depending on the trimester. If it's first trimester, what would be the primary problem? It's already there.
Nausea, vomiting.
Okay, it's important to specifically ask for nausea, bleeding, abdominal pain, because these are the most common symptoms of a pending abortion. Of course, there are a lot of changes that will occur in our body, primarily breast changes. What are the signs that we have encountered? These are the changes in the breast. Okay, this is your linea nigra. Okay. And of course, your cervix, you have your signs. Most common would be your Chadwicks, your Higars, which would be change in color and softening of the isthmus, respectively. Okay? Okay. Of course, you have your other differentials, as I've mentioned. Amenorrhea could be cause a lot of things. So it could be an abdominal mass. It could be the following. Right? So this is your presence of HCG and how it behaves. Okay? So in the first 5 to first 15 weeks, your HCG would increase, then rapidly decrease, etc., etc. Okay? So your ultrasound, what's important is first trimester, you have your crown rump length. Second trimester, the most reliable indicator would be what? Your biparietal diameter. And your third trimester, most reliable would be your femoral length. Okay, I went ahead of my slides. I'm sorry. There are also non-biometric parameters. For example, if you have conflicting um, areas, you look at the maturity of the placenta, if it's grade 1, grade 2, or grade 3. Okay. Okay. Now we're at our second trimester at around 17 to 28 weeks amenorrhea. So the abdomen would continue to enlarge and there would be start of your fetal movement. Okay. So you ask, why is quickening important? So these are for patients that would not be sure of your menses. You could go back to quickening. You could go back to fundic height to tell you the approximate age of gestation. So for example, if you're in the quiz that we've had, if your fundic height is at the umbilicus, what is your estimated age of gestation?
20 week.
Okay, so your estimated age of gestation would be at 20 weeks. Okay. So again, there would be different clinical signs. You have your Braxton Hicks contractions. So most often this would be confused with true labor. So your Braxton Hicks would be a contraction that would be more or less related to movement. It would not occur with regularity. So it is not an indicator of preterm labor. Okay. Of course, we could start with the auscultation by 21 weeks. You could hear the fetal heart tones 100% even through the inexperienced ear. Although in Williams, I know that it's been said that it's 17 weeks you could detect the fetal heart tones. However, that would be for clinically experienced physicians. But at 22 weeks, even to the inexperienced ear or to your patient or to a newly training resident or clerk, 22 weeks you have to hear the heart tones by stethoscope. Is that clear? Okay, so you know this maneuver. You have your Leopold. What would your Leopold 1 tell you? What will your Leopolds tell you?
About the position of fetus, ma'am.
Okay. What is your LM1?
The fundal grip.
Okay. LM1 is your fundal grip. It checks if your head or your buttocks is occupying the fetus. What is your LM2 then?
Umbilical grip.
Is it your umbilical grip? Okay, you look at the sides. And what will you palpate for?
Paraumbilical area.
Okay, you look at the fetal back,
Feel
not
the
umbilical
fetal
area.
part. Yes.
You look at the fetal back and your fetal limbs. Why is it important to determine? Because you will find the heart tones on what side?
Left.
On back of
The back
fetus.
of the fetus.
That's correct. You will find the fetal heart tones on the side of the fetal back. What is your LM3?
Poly grip.
So it's your polyps grip. So it will confirm your findings in your first Leopold's if the head is at the presenting part or the buttocks is the presenting part. And what is your LM4?
Pelvic grip.
Pelvic grip.
Pelvic grip. Pelvic grip. Okay. So you will look if there is already engagement. You only do this when there's already engagement. And this is the only Leopold's maneuver that is done facing the feet of the patient. Okay? So you will still see the bluish discoloration, Chadwick sign, second trimester, and you could start doing your bimanual examination on the uterus. You would see the enlargement, etc., etc. Okay. Still differential would be an abdominal mass. Okay? No more HCG because by that time, your beta HCG would have what? By the second trimester, what happens to your beta HCG?
Decreases.
It would be decreases.
It would have had decreased, so it would not be diagnostic anymore. What is done is your abdominal sonography. Again, for the second trimester, what is the most reliable indicator? If it's first CRL, third femoral length, what is for second trimester? According to ultrasound.
Biparietal diameter.
It is your biparietal diameter. So never confuse the three. Okay. So these are your different clinical signs still present. Melasma, your breasts are still tender, abdomen is enlarged, you will still see your linea nigra, your perineum will be more pigmented, etc., etc. Of course, essential in your second and third trimester physical examination would be, as mentioned, your Leopold's maneuver. Okay, you have to know when it is estimate depending on the age of gestation, your fundic height, how it relates. Okay. So this is the Leopold's. Okay. 29 to 40 weeks. It's third trimester now. So what are the changes that we have to anticipate in your third trimester? Okay. Still the same, your bluish discoloration. Important in your third trimester examination, especially when the patient is about to deliver, would be your internal examination. Okay. Your internal examination, when you do your internal examination when patient is about to go into labor, what are the important things that your internal examination would tell you? Okay, ultrasound would have what are the important things that your ultrasound, your internal examination would tell you? We are going into your second lecture already. I am relating it to your second lecture. Your internal examination would give you an assessment not only of your dilatation, but also on the adequacy of your pelvis. And what is that? You did not want the technical aspect of the lectures. Evaluation of pelvis. Okay, let me go back to that. Let's just finish this. Presumptive evidence, you know that it is presumptive. So this could be caused by other conditions. That's why it's presumptive. Probable evidence of pregnancy, this increases the chance. So these are probable evidences. And the only positive signs of pregnancy would be 3. You should identify fetal heart tone separately from the mother, fetal movements by the examiner and not by the mother, and by ultrasound recognition of the embryo. Okay? So this is a computation of your gestational age. If you do not know the LMP, you could use quickening or your fundic height plus 4 or ultrasound examination. Okay. I think you need the other lecture more. Let me search. Okay. When doing the internal examination, what are the things that you have to, what that your internal examination will give you? Anyone?
Ma'am, we would get to know about, is there any kind of the congenital anomalies in fetus, or about the proper right condition of the uterus for right time, and that kind of information.
Internal examination, you will put your second and middle finger in your patient.
Ma'am, we can know the length of the cervix by putting those 2 fingers.
You could know the length of the cervix. What else? What other information would your internal examination give you?
Position of the cervix.
Okay, you have the position of the cervix. If it's anterior, midline, or posterior, that's correct. What else?
Softening.
If it's soft, firm, or
Position of the baby.
okay. So you have your position, you have your consistency, that's the softening. If it's firm, soft, or mid, what else? What else?
Size, doctor, size.
Size. Okay. What am I looking for? What score am I looking for to know if it is favorable for normal delivery?
And by that means we can evaluate whether whether if there is a cervical weakness which can lead to miscarriage or preterm labor.
Okay, so you have your dilation. You have mentioned 2 others: consistency and your position. What else?
Also look for the membrane.
Membranes, the status of the membranes. What else? What consists of your Bishop score? What makes up your Bishop score? You have already given 3. Dilatation, fetal position, direct and transfer. What else? You have given your position, your station, I gave the other one. The other one is position, dilatation, consistency. What are the other 2? It is your
The position of fetal head in relation to the pelvic bones.
it is your effacement, and what is the other one? Bishop score. So this one would tell you if it grade score more than 7 would tell you if your fetus is viable, favorable for induction. Okay? So this is your fetal evaluation. Of course, we could not do anything with it if we did not review your anatomy. Okay? So these would be your planes and your true pelvis. Okay. So you have known this. Clinically, what's important would be um, your fetus also has your different anatomy, your sutures. Okay. Clinically, how do we apply this? Okay, you've had this in your review. Okay, so what's important is your fetal lie and your fetal attitude. Okay, habitus, okay, as shown in the slide, is the ratio of the limbs of the fetus and the head to his body. Okay, so most favorable would be the curved spine. So legs are flexed. So hands are flexed also at the elbows and intersect on chest. So fetal lie, so you would have your cephalic, you have your breech, you have your transverse, you have your shoulder presentation. Although 97% to 99% would be cephalic and seldom will we get the other presentations. Okay? Okay, and this would depend on your station. Okay, this would be in relation to your anterior, superior, inferior spine. Okay, so we could examine. So this is where your internal examination would go in. How do we examine your pelvis? Okay, you've had the previous slides in anatomy. It was just a review. So clinically, so you look at your pregnant patient and survey in general the patient. Okay, such that, okay, aside from external measurement of the fundic height, etc., this is your Leopold's. We have discussed this prior. Okay, your IE would tell you, aside from the Bishop score, your pelvimetry. And what will your pelvimetry tell you? What will your pelvimetry tell you? Anyone? You would see if the patient has an adequate pelvis. And what will comprise an adequate pelvis? Okay, what are the important parameters when you do your internal examination? What is this? This is your diagonal conjugate. And what would your diagonal conjugate tell you?
Hello.
Anyone?
Hello. Yes, ma'am.
Yes.
It is actually the only anterior posterior measuring distance.
Okay,
Like
so you measure this from the symphysis pubis to your sacral promontory. If you're able to reach your sacral promontory, what does it mean?
it was an inlet into the pelvic, ma'am.
Okay, so it means your pelvis is contracted and most likely your baby's head would not traverse your pelvic inlet. So your inlet would just have one parameter and that is your sacral promontory. Okay. What are the parameters of your midplane? Okay. So memorize this one. Okay. Your inlet is your sacral promontory. Your midplane would be a hollowed sacral curvature, parallel side pelvic side walls, interspinous diameter, and sacrosciatic notch could admit 1 to 2 finger breadths. Your outlet should have a movable coccyx, suprapubic angle of more than 90 degrees, and your bituberous diameter should admit a fist. Okay? So again, this is your pelvic inlet formed by your promontory. Okay? This is clinically important because if your inlet is contracted, your diagonal conjugate is less than how many centimeters? 11.5. You cannot proceed with vaginal delivery or you could do an outright cesarean section. Okay, so this is your midplane. So this is your sacral curvature. This is your side walls. This is your interspinous diameter. And this is your sacrosciatic notch. So your outlet, so you have your coccyx. So you have your bituberous diameter and your suprapubic arc. Okay. Any questions for this session? I will check. I will verify your answers. But the MS forms will primarily count as your attendance. If your coordinator would ask if I gave quizzes, only then will I give the quiz. So that if ever we have to award bonus points for some who are lacking in grades. All right. Are there any questions with this today's lecture?
No, doctor.
If there's none, you may leave this call. Thank you. All right.